So we want to talk about perfect blood sugar and insulin control, and it doesn't always have to be perfect for you to get pregnant, but getting it as good as you can is really important before you get pregnant and during pregnancy. And not just the blood sugar, but also we're going to emphasize insulin levels, okay? So as mothers or potential mothers, it's very, very important that we actually really regard our body as a temple and do the best we can to be as healthy as we can. So, you know, that's part of our endeavor here. I'm going to answer the questions. What are glucose and insulin? How do they impact fertility? How do we diagnose problems in glucose and insulin especially? That's a tricky one. And then how do we treat problems once they're diagnosed? So glucose, I think we probably all know that. It's a sugar that's the main fuel used by the body, and the body makes it from carbohydrates, from milk, from starches, from sugars, vegetables. It's in many different types of food. And protein in excess can also be converted into glucose. And it's stored in the liver as glycogen, but then it's used as a fuel in many organs, in muscles, in the brain, and other organs in the body. Now, insulin is a hormone made by the pancreas, and it allows muscles to use glucose for energy and the liver to store glucose for future use. So it's sort of like the insulin opens the gate for the glucose to go into the cell. And then insulin also does other things in signaling in the metabolic processes. So then there's insulin, high levels of insulin, and you can either have hyperinsulinemia, where it's just high insulin, but then there's also resistance. So you can sort of look as high insulin as an adaptive mechanism, because your body is going to try to keep the blood sugar normal. But sometimes in order to do that, it has to make more and more and more insulin in order to keep the blood sugar normal. And then when that process gets down or gets broken down, then you may become pre-diabetic or even diabetic. So we can look at all these issues as kind of on a spectrum, from a little bit hyperinsulinemia, and then the insulin is rising in order to prevent the glucose from being too high. And then eventually the glucose may break down and then eventually end up in the diabetic state. So they're a little bit independent of one another, and there are different variations on this. And I think I was originally taught that sort of it was the straight arrow between pre-diabetes and diabetes, but it isn't always like that. So some people can be here with high insulin levels for years and years and years and have more damage to their organs than somebody with diabetes. And some people will develop high blood sugar early and their insulin won't be as bad. So you kind of have to test both to see where you are on the spectrum. So how do they impact, glucose and insulin impact fertility? A lot. There's just many reactions and aspects of fertility. First of all, insulin receptors are present in all the cells. It involves in signaling between the pituitary gland and the ovary. That's the FSH that stimulates the ovary. Insulin is involved in that. It can disrupt egg maturation, disrupt ovulation, and even affect chromosomes and produce inflammation. So here, every month, if things are working, the FSH stimulates the ovary to produce follicles and mature, and the LH stimulates the ovary to release the egg. And insulin, if it's excessive, can mess up these signals. And then also, if you have a lot of high blood levels of sugar, high blood levels of insulin, this is your follicle that's developing. It can interfere with this, especially PCOS, Polycystic Ovarian Syndrome. A lot of people with that have high insulin, and what we see in that is the follicle can start to develop and it doesn't go all the way to ovulate, and then it regresses, and then another follicle comes along, and then finally, then there'll be one that ovulates. So often people with PCOS have infrequent periods every 2 months, every 3 months from the follicles not going all the way, and the high insulin can really be the thing that prevents it. Then also insulin and glucose can affect chromosome divisions. Now we think this is related to age. In a way it is. The old eggs have a worse chance of having chromosomes that are abnormal, but really a lot of chromosome problems take place in the 3 or 4 months before ovulation. And somebody has their thing on. Okay. Anyway, it takes place in the 3 or 4 months before ovulation. What has to happen is your eggs that you have in your body since fetal life have actually 46 chromosomes like you. And then in order to join with the sperm, they have to get down to 23 chromosomes. So there's a couple of different processes in there, but they really happen very, very shortly before ovulation. And so your sugar can impact them. Even if you're 39 years old, 42 years old, if you optimize your sugar, you can actually have a big influence on what's going on with the chromosomes. So we also find that very mild elevations in blood sugar have an impact on fertility. I don't know, have you heard of hemoglobin A1c? That measures your glucose for the last 3 months. And so you'll be told that, 5.6, that's fine. You're not pre-diabetic. Pre-diabetes starts at 5.7, but actually the pregnancy rate is double in the lower third. That's meaning like 4.9, 5.0, than high normal, which would be 5.5, 5.6. So optimal is better than high normal by a lot. Okay, this is a very common hormone problem, polycystic ovarian hormone syndrome. So many women with this are heavy, but there's also thin women that have this. So it's not directly related to insulin resistance, but there's a lot of overlap. 70% of women have insulin resistance. 10% have actual diabetes, and often it's undiagnosed. And these are the criteria. Blood sugar and insulin are not in here, but this is if you hit 2 out of the 3, you have PCOS, long cycles over 35 days, high male hormones, ultrasounds that look like this, that are all these little follicles that didn't make it.
Oh boy.
Okay, so anyway, so overweight and obesity are related to insulin resistance, but like I said, thin people can have it too. And so we talk about egg quality. What we mean often is chromosomes, and these are our views of the human egg, but they're very, very affected by blood sugar and insulin. And this is stressed in actually a really good book. Unfortunately, it's a little bit IVF oriented, but nonetheless, there's a lot of research in it that's excellent about how to make your eggs better. Okay, so it's called It Starts with the Egg by Robin Fett. It was came out about 5 years ago. So there's a lot of good information about the impact of glucose and insulin in there. So how do we diagnose glucose and insulin? Now, if you test blood sugar, can you tell if there's any problem with the insulin? You can't. You actually have to test both. Okay, so this is kind of the gold standard in how do you diagnose a glucose insulin problem. And this won't happen in your clinical life. This is a research thing, okay, but they'll take a research subject and squirt in IVs glucose and insulin into them, and then find out what happens and how fast the muscles take up the glucose and how much insulin does it take to do that. So this is very impractical, but there's a practical way where a number of these people have been studied, and then the tests in a more ordinary kind of test, a glucose tolerance test, compared to this. So there is a very high correlation. And what you do is you do a our oral glucose tolerance test, which Quest Lab, LabCorp, all the labs do this. So this is a glucose challenge. It's a very similar test that you do for diabetes. And then you also test the insulin response to glucose. So you do a fasting test, you take 75 grams of glucose, which they have in the lab, that's a sweet drink. And then in 1 hour, you measure the glucose and the insulin. In 2 hours, you do the same thing. So then once you do this test and get the lab to do it right, and that can be a little tricky, you have to interpret them. And I have to say, until really recently, I didn't understand this. And it was finally by studying with a wonderful endocrinologist whose name is Pilar Vigil, who's the main endocrinologist for FEM, that I understood this. So what you have to recognize is that the regular lab references that are given at LabCorp or Quest and what you see and what I was trained to do and family practice doctors are trained to do, they don't have very much to do with fertility. They really have to do with cardiovascular disease and people in their 50s and 60s. And the standards for having your ovary work are much stricter. So what they say is normal, like this insulin level of 12, they say, oh, that's fine, it's under 17, but it isn't fine. Okay, it's not fine for fertility. And the hemoglobin A1c 5.4, that's actually not too bad, but it's really better if it's 4.9, 5.0, 5.1 maybe. So, you have to be thinking in what are the optimal terms if you're having an issue with ovulation. So this is kind of a complicated slide here, but the very good definitive study was done by Pilar Vigil and her colleagues in Chile. And this is the 3-hour test. And they correlated this with the people that had the gold standard test. And actually, the people who were not insulin resistant had very, very narrow range of glucose and insulin. So if we compare what they got to Quest Lab, here pre-diabetes for a fasting glucose starts 1 over this at 100. Really, if you have good fasting blood sugar, it should be 90 or under. And these numbers should be more like this. And the insulins are even deviate more, I would say, from what we see at Quest. So if through hook or crook and various means, you can get these levels down here, it'll have a superb impact on fertility and also on miscarriage. So who should do this testing? Anybody overweight, older women, PCOS, family history of diabetes, fatty liver, any abnormal glucose, any miscarriage. I would advocate you should go through the full 2-hour testing and could benefit from, do you have this condition or not? And so what if we find out you have insulin resistance or high insulin? How do we treat it? The important thing, the first thing, is a low carb diet. So there's many different kinds of low carb diets. Ludwig Whole30 Keto is a very radical diet that isn't necessarily suitable for a lot of people unless they need a big weight loss. But you can learn about diet and glycemic index, but we all know how unhealthy people in the US got when fats were demonized and everybody was encouraged to have tons of whole grains, and that was the bottom of the food pyramid. This is not a good idea if you have insulin resistance. Even a more conventional food plate with grains on it may not be good. What may be better is a Mediterranean diet with more veggies and actually a more emphasis on good fats. Okay. So anyway, in terms of diet, the change that's easiest and quickest is to change the breakfast to be lower carb if you have this condition and have more fats. And the kind of exercise that helps, it can be very moderate, like walking or whatever, but if it's frequent, if you do it like 5 days a week, that can actually change your metabolism. And it'll change it a lot more than going to the gym and doing weights a couple times a week or even aerobic. If it's just consistent, then it can really help get rid of insulin resistance. So this is a simple low carb diet. limit bread to 1 serving a day, small servings of healthy grains, lots of vegetables, more fat, legumes, 2 fruits a day. And there's a variety of good diets that you could do for low carb. Then some supplements that are helpful. One we find for people with real insulin resistance is Myo-Inositol. Now, there's actually a receptor on all the cells that's the inositol receptor for insulin. And so that's what's helping the glucose go into the cell. And you can make your body much, much more receptive to insulin by taking Myo-Inositol. So you need to take a lot. Like if you look at the amounts, 2,000 2 times a day, that's kind of a lot of Myo-Inositol if it's in pills. So very often it's in a powder, and you take a teaspoon of a powder and you mix it in water, and it doesn't taste bad. So this is something that's frequently done for glucose and insulin resistance. And the Myo-Inositol works better if it's mixed with D-chiro-inositol, just a little bit of that in a 40-to-1 ratio. Then carnitine is a very good amino acid, especially during pregnancy. In Germany, they use this a lot for pregnant women, and helps prevent pregnancy diabetes. And then vitamin D is actually really important for insulin glucose regulation too. So these are 2 good brands of Myo and D-chiro-inositol. It's involved in pituitary ovarian axis signaling, also in androgen, the male hormone, in polycystic ovarian syndrome. So this is actually a really good product to get. And then vitamin D is important. It's good to know your vitamin D level. Actually, an optimal level is really over 50. Now, some of the labs will say 20 is fine or 30 is fine, but for both COVID protection, breast cancer, and also fertility and insulin, 50 to 80 is the sweet spot for vitamin D. And I need to make you aware that there's a lot of bad dietary supplements. Okay, so in fact, in the state of New York, there was a raid that the Attorney General did on Walgreens, Walmart, and GNC, and they found, this is especially herbs, okay, but they didn't have the herbs on the label that were advertised on the label. They had rice, houseplants. There's garbage in the supplement industry, okay? So the way you know you get a good supplement is you get good brands, and you want to be sure that they're tested with independent laboratory testing. And in fact, a good supplement company will say, well, you have the certificate for this carnitine, and they'll be able to provide it. So the other way you figure that out is you go with a good brand like Metagenics, Thorne, Claire Labs. There's many, many good brands, but you're kind of on your own if you just get something off the internet, okay? You probably want to know more about that it has the potency and purity. And that there's also bad impurities from Chinese substrates that they use for making the vitamins. So anyway, the good companies will check them all. And then I have to mention Metformin. Okay, that is the most important drug we use for insulin resistance. It's very, it works fast. And for example, for polycystic ovarian syndrome, where people aren't ovulating well, it's a well-known therapy. We just put people with PCOS on metformin sometimes. Now, it's good if you do the testing before, but this has been a known therapy that for women who don't ovulate, 40% of them will ovulate if they're put on metformin, and especially with a diet and other means. And then these are sort of more tricky medicines to use, but there are some people who need them. For example, someone very, very, very overweight, getting up into the over 250 pounds or something with really high insulin levels, they may need a lot of stuff to get the insulin level down. So sometimes you would combine these medicines. So at any rate, how do you figure out what to do? This would be good to do with your physician, but if you're 20 years old, you're not getting married or planning to have children for a while, and you just want to be healthy, you can take 2 years just with diet and maybe some supplements and try to get your levels down. If you're intermediate age, maybe the Myo-Inositol would be good for you. If you're older and over 35 and you have a difficult insulin problem, and PCOS, you might want to go more quickly to the Metformin. It will get you in good shape to be pregnant much faster. And even though some people try their best, they can't necessarily do it with diet or supplements, even though that may be the preference. And the other good thing about Metformin is it prevents miscarriages. There's data that if you're on Metformin for the first trimester, you'll have fewer miscarriages. So it's an important medicine for people that have frequent pregnancy losses. So basically, it lowers fasting insulin, it lowers testosterone, it enhances live birth rates and pregnancy rates, it decreases stress, suppresses inflammation. So I use a lot of that actually with people with fertility, and I have a very low threshold for using it. And certainly there are other ways of treating this, but this can often be the best way. So I have a couple case presentations of people. I'm going to go through these really quickly, but the main point of this one is like these numbers aren't good enough. Okay, this person was insulin resistant. Now she's somebody who was 41. She had failed infertility treatments with intrauterine insemination, IVF. She had spent $25,000, okay, and she was premenopausal, but her fasting insulin or her fasting glucose was 96. Her A1c was 5.6. So this is getting close. It wasn't pre-diabetic. It was normal, but not very good. And when we did these 2-hour tests on her, she had blood sugar levels in the 200s. They hadn't even done a 2-hour blood sugar test on her. And the insulin was very high. And so when she was put on a proper diet and therapy, she ended up getting pregnant fairly easily on Metformin. Now she hasn't had a live pregnancy level yet, or a live full-term pregnancy yet, but she improved pretty quick once she got the glucose and insulin, which had been underdiagnosed, okay, before that. And then here's a lady kind of past the point of fertility. She had kind of given up on it because she had been through the mill. So we see body mass index 35, so quite overweight, weight up in the 200s, and she had very, very severe endometriosis where she had had a ton of surgeries. And she had her left ovary out, and so she was trying to control this with anti-endometriosis drugs, that kind of thing, in a lot of pain. So this is what happened with her. Fasting blood sugar. This lady had totally normal blood sugars. Her A1c was barely pre-diabetic, but look at her insulins. I mean, off the wall in the 500s with 45, So she was put on a whole bunch of stuff, but Metformin, Myo-Inositol, later the stronger drugs, okay, like Actos. And she improved a lot. So I think she's past the point of being helped for fertility, but for pain, fixing her insulin, we didn't get it normal yet. We want to get it down to 7, but brought it down from 45 to 17 in just 1 month, and the A1c got better. And her inflammation got way better. So, I mean, it isn't just for fertility. This has broad implications for, many different organ systems, correcting the insulin. And then finally, this is this very interesting woman who was 45 years old. She had 2 early miscarriages. Finally, at age 39, managed to have a normal pregnancy. And then in her early 40s, she had 3 early miscarriages, and she had chromosome tests on them, and 2 of them had abnormal chromosomes. And so this lady really worked on herself, and she was a little bit overweight, had borderline fatty liver that you get from insulin resistance. Her other studies were normal. Her fasting insulin, glucose was at first pre-diabetic. Her A1c, not too bad. She worked on herself and got herself to where she lost a little weight, had a totally normal glucose test, but she was told with her chromosome bursts, you're over the hill, your eggs are too old, they're poor quality, give it up, you're 45 years old, you know? So we did the insulin test on her, and there was still room for improvement. Like this number should be less than 7, that one should be less than 60, that one should be less than 45. So basically we put her on metformin, and she already had really good habits and a little bit of progesterone and a lot of vitamin D. And she actually conceived fairly quickly after that. And she actually, I think she's going to give birth anytime soon, sometime really soon. But she has a normal boy with normal chromosomes after all those losses. And can't totally take credit that there's God in this and not just the glucose and insulin, but she was able to correct this situation and really help her metabolism a lot. So just to summarize this, the thing about blood sugar and insulin is they're very treatable causes of infertility and miscarriage that you can work on. And the high insulin is greatly underdiagnosed. If you're told that, oh, this is normal, it might not be optimal. It might not be optimal. Like the stricter control is really important. And I think the very best method, now, not everybody needs this, okay, but many, many people do this 2-hour test where you get the 3 samples of the glucose and the 3 samples of the insulin. And then what do you do about it? Diet, exercise, supplements, and then sometimes the pharmaceuticals.